Welcome back to Think Like a Nurse 2. Today our focus is going to be on our respiratory review of systems or the assessment piece of how we look at our clientele. Everything that we do in nursing is so very important. One of the most important things that we focus on is going to be our assessment of our client. What we're looking for as far as that assessment piece is how the client actually presents physically to you. What do you know about the client from historical data that has been gathered? And also, as far as your family history, do you know anything from the previous experiences of the client? Have they been exposed to any type of disease or disorder? All those kinds of things are called data collection. And your data collection is going to be very helpful in making your assessment on these clients. One of the first things we learned about as far as fundamentally is regarding auscultation, and that means simply that you're taking your stethoscope and you're learning, which would have been much more previous knowledge as far as your fundamentals regarding where to place that stethoscope. And remember that your stethoscope has a diaphragm and a bell. What we're going to be listening to through the adult is we're going to place on the stethoscope and we're going to be listening through the diaphragm of the piece of equipment. When we listen to those lung sounds, that's where your auscultation comes in. We're going to place that stethoscope on those significant points on the chest, on either side, both front and back, and we're going to be listening to the sounds of the lungs. If you're unable to recall what a lung sound specifically is, remember that your abnormal lung sounds are called adventitious. A-D-V-E-N-T-I-T-I-O-U-S. Adventitious lung sounds. And those just mean that there are sounds that are there that should not be there. Once you develop a more critical ear for listening and have more nursing and clinical experience, you can start to decipher and determine what those different lung sounds are sounding like. When we have clients with specific disorders, which we're going to be talking about on our next segment, that is going to give us significant information about what types of sounds that we may hear or that we may expect to hear in clients that have disorders. So first of all, we have to understand what auscultation means, where we place our stethoscope in order to gather the assessment. Remember that the right lung has 3 lobes and the left lung has 2 lobes. What we should expect to hear is called clear lung sounds, and that happens in a client that is a normal individual that has no history of pulmonary dysfunction. We would expect to hear a clear exchange of gases when the client inhales and then exhales air. What we're looking at as far as other lung sounds are concerned, we're listening for crackles, which are, if you can imagine, bubble wrap, like popping bubble wrap. Those are the crackly, or taking a piece of saran wrap and then kind of crumbling it up close to the ear, or taking a piece of hair and listen to the little clickety sound it makes when you rub it in front of the ear. Those are sounds that we're listening to, and the crackles indicate that there are wet sounds inside the lung fields, and therefore those are sounds that should not be present. Also, what you hear, and generally this happens in our asthmatic clients, is more of a wheezing or a musical type sound. And those can be heard either inspiratorily or expiratorily, depending upon the client's disorder or the severity of the problem that they're having. If we're auscultating and we hear, and you can hear this a lot of times when a client is in severe respiratory distress, and even without your stethoscope, they will have what's called stridor, S-T-R-I-D-O-R, stridor. And this means that they're having an extreme spasm of their bronchus, or an extreme bronchospasm. This can happen as a result of being exposed to an allergen, or it can be happen when a client is experiencing anaphylaxis or extreme respiratory distress. What we're also listening for is those snoring type lung sounds. And those type lung sounds are called rhonchi or stertorous, S-T-E-R-T-O-R-O-U-S, stertorous lung sounds, because those sound like snoring. Okay, and lung sounds, abnormal lung sounds, don't necessarily have to be heard in both lungs. Typically, if you have a client with a specific disorder, you may hear lung sounds bilaterally, which means on the right and the left. Or if they just have one dysfunctional lobe, you may only hear abnormal sounds on one side. And we'll talk about that again more in detail when we get to our actual disorders. So we've talked about rhonchi, we've talked about crackles. We also want to understand that clients may have what's called rales, R-A-L-E-S. Those are lung sounds where you may hear bubbling in the lung fields, and that also indicates that there is some type of fluid. If you are auscultating lung sounds and you are not hearing a clear exchange of air coming in or air going out, then that client may have what's called diminished lung sounds or absent lung sounds. And this is very, very critical. Anytime you are not able to hear lung sounds appropriately, always assume that it may be your assessment, and then you restructure and you reorganize, troubleshoot, listen again, and then that will help you make the determination as to whether or not it may have been something that you heard, or perhaps you had your bell turned on instead of your diaphragm on your stethoscope. So always assume first that it may be an error on your behalf, and then reassess. Part of our assessment, again, is going back to those physical characteristics and physical presentation of the client. Does the client show any signs or symptoms of respiratory distress? In part of our assessment, what we're looking at, that's the look piece. We're looking. We already did the auscultation, and we said we listen, and then we feel. If we're unsure if a client is actually breathing, then what's your assessment? You place your hand on their chest to make sure that you are feeling those respiratory efforts. Okay, you're watching, you're looking and watching. That's part of your observation as a nurse, and that's one of your very acute senses that you will use very frequently. What we're also looking at as part of our assessment piece or our review of systems is looking at the symmetry of how down the sternum we would divide the body into that imaginary line down the midline. And we're looking at the right lung versus the left lung. And remember that everything is directly in reference to the client. The right lung versus the left lung. You are determining whether or not there is a symmetric rise and fall of the chest. And if the client, if you're noticing that there is asymmetry between the right and the left side or vice versa, then that means that one of those lungs has been compromised and that client may be having some type of respiratory distress. But we'll focus more on that when we get to our disorders. Right now, I just wanted to bring you in and just kind of remind you about some of the fundamental things that you've already learned before we get to the disorders, because before you start learning about and being able to understand and synthesize those disorders, you really have to understand the form and the function. I hope this has been helpful to you, and I hope you will join me again very shortly for our next segment, which will focus on our respiratory disorders. Thank you.